Welcome, everyone. We are excited to have you all with us today. I am Alissa Link, I'm Director of Operations at Lin Health, and I'm excited to introduce my co-host, Dr. Antje Barreveld, and who is the Medical Director of Pain Management Services at Newton-Wellesley Hospital and an Assistant Professor at Tufts University. And we are excited to share this conversation with you all today. Please feel free to submit your questions. We have some of our team members ready to answer, and we will be addressing audience questions at the end. So without further ado, I wanted to also give a brief note that we will be offering an exclusive promotion at the end of the webinar, so do stick around so you can take advantage of that. And we will get started. All right, so let's start with some of the basics. And I'd love to hear a little bit about how you define pain and some of the current paradigm around chronic pain.
See everyone, and Alissa, thank you for the introduction. I would like to say that I'm a pain management physician, so I see this every day. And for me, I think one of the hardest things for patients to express to other physicians as well as to friends and family is really what it feels like. And chronic pain, there's a definition of chronic pain if we want to put that up. What is important for us to note is that it is a subjective experience. It's what you are experiencing, I'm experiencing, or someone that we know well. And that means that there's a lot of information coming in, whether that's information coming from the brain or information coming from an injury that happens in a hand or in another peripheral limb. And it's complicated, and we'll show how it is complicated, but it really is a subjective experience defined by an unpleasant sensory and emotional experience where you may have actual or perceived tissue damage. And for me, there's no test for pain per se. There's no blood test. There's not necessarily an easy scan that we can do. So it's really listening to the person themselves, and sort of what they're experiencing and how they're processing the pain. It is an individual experience.
Yeah, that's really interesting, in that concept of the sort of subjectivity and the lack of testing for pain, right, compared to many other things in medicine where we have lab tests or imaging or things that can really give great evidence and things to base clinical practice off. So how does that aspect of pain and its definition sort of impact treatment?
I think that's an excellent question, Alissa. I think that the problem that patients face is often that they feel dismissed, or they feel, well, I don't have a lab test, or I don't have a study, or I have something that shows something that's wrong, but my doctor doesn't feel like that's the cause. And I think some people feel really disheartened when there isn't something that is truly amiss. However, that doesn't mean that the pain isn't real. So I think for myself as a pain provider, what's so important to remember is that even though we don't necessarily have a test, or let's say we have a test that shows something, but I'm not treating the MRI or I'm not treating the lab work, I'm treating you, the patient. And so I need to know exactly what it is someone is experiencing to be able to tailor treatments or be able to kind of personalize what someone needs, again, based on what they're feeling subjectively and not what something is telling me. So that helps me to kind of understand, well, how is this impacting your functioning? How is this affecting you in other ways, not just physically, but also mentally, and really understanding what that experience is like for the individual is how we can focus our treatments and tailor our treatments.
Absolutely, that piece is so important around, all of the other aspects that pain and chronic illness can touch in our lives.
So when we look at this slide here, I think that's where that complicated web really shines. There isn't always one clear-cut explanation as to why someone is experiencing pain, and there are so many other factors that come to play, whether it's that an injury happened, but then we need to be thinking about how is the patient coping, and for a lot of people that also highlights a red flag where they think, well, I'm trying, I am trying to cope. This is not it. This is not in my head. This is real pain. And that is the case. However, we all process pain differently. And it doesn't mean that someone is weaker or stronger than someone else. It just means that the way our brain is wired is the way it is wired. And are there ways that we can modify that wiring? That's where things like looking at coping mechanisms can be very helpful. And then we add on, as I always tell my patients, as pain goes up, stress goes up. As pain goes up, anxiety goes up, depression gets worse. So all of these things are interrelated. And when we can look at these impacts on our mood and on our central nervous system processing, then there might be ways that we can modify that subjective pain experience so that someone isn't suffering so much. But it is complicated. It doesn't mean that we can't treat pain. We absolutely can. There isn't always an easy solution, however.
So you mentioned the idea of stress and anxiety. What does behavioral medicine have to do with chronic pain, and how do the two overlap?
That's a great question. I think when I talk about what our pain psychologists do or what other pain psychologists can do for patients, again, sometimes people feel immediately stigmatized. That said, behavioral medicine is, if I didn't have my psychologist, I don't think I would do as good a job at managing my patient's pain. And that's because it takes a team. Where behavioral medicine plays a role is really, it definitely takes a longer conversation to really explain the science behind it. But the science is really quite robust, that if we can find ways to rewire the way that our brain is firing, that is not necessarily a medication or something like exercise or other physical activity, nutrition, many of the things that are so important in managing pain. But when we really look at our coping mechanisms, the way that stress plays a role in kind of perpetuating pain and reframing sort of our day-to-day activities, we can make a big difference. Even though the pain may not go away, we can definitely make the pain more manageable. And that's where behavioral medicine is key. I think this slide is really telling that this is a way to test the pain's effect on the brain. But most of the modalities that we use to look at the effect of pain on the brain are used in research only because they are complicated and very costly. This study, though it's a little bit older, is so interesting because it shows that our brain shrinks over time when we are exposed to, in this case, chronic low back pain versus someone who is not experiencing low back pain has a statistically significant increased density in their gray matter in the brain. But we know that this is reversible, which is even, I think, more interesting, is that if we can treat pain, we can actually see a difference in how the brain is firing and even the volume density of brain matter. So I think that that research evidence is how I try to convey to my patients that it's not necessarily a medication or a surgery that will fix this change that happens in the brain. There's other things that we need to be thinking about because they're all interrelated.
That is fascinating. What an interesting study. I'd love to hear more about the use of medications. It's come up a couple of times now, and I know that for many people, pain medication is sort of the frontline treatment or one of the things people look to first. So I'd love to hear from your perspective, what is the role of medications in pain care and in sort of this modern pain care model?
I think medications have a definite role in acute pain, and the question really is about chronic pain. That's where it's not always that obvious. And unfortunately, we don't have a lot of medications to choose from. So there's many classes of medications for pain, and some of them work on these centrally needed mechanisms, like the antidepressant classes. So they're not necessarily treating depression per se, but they're working on those same neural mechanisms that are involved in depression also can be involved in pain. So that's why some antidepressants help with managing pain as well. Then there are other things like local anesthetics, like a lidocaine patch that we can put on the skin, and that can be helpful more in the peripheral sense. And I do find that all of these classes of medications can be helpful. Again, it's definitely easier for someone like myself with my background to treat acute pain with medications than often with chronic pain. And that's because medications are really only one part of the entire sort of armamentarium that we have for treating chronic pain. And for some patients, some medications can be life altering and can really be extremely helpful. I have patients, for instance, who have severe nerve pain or complex regional pain syndrome in a hand or in a foot. And some of the nerve medicines, such as the anti-seizure class of medications that people may have heard of, the gabapentinoids, gabapentin or pregabalin, also called Lyrica, those have really allowed some patients to really function. But sadly, a lot of our medications come with side effects. And that's where the limitations often lie, not just in how are they helping someone function, but can they tolerate the side effects? Things that are common with the antidepressant class and the anti-seizure classes are weight gain, fatigue, feeling really tired, sometimes irritable. Sometimes they affect mood in the wrong way. So people actually feel worse when it comes to their mood, or they feel more agitated, or it's even the opposite effect of feeling tired. They can't sleep. And so it's weighing the risks and the benefits of a medication, trying something starting at the lowest dose and kind of titrating it as possible to minimize those side effects is sort of our general strategy. So although I do find that medications do have a role there are lots of limitations, and again, we need more classes of drugs. We don't have a fantastic armamentarium of drugs that are helpful that don't come with side effects. Even something like an anti-inflammatory comes with quite a lot of risks.
Hmm. That's interesting, especially when some of those side effects you listed, I know in a lot of the members we work with, those are often symptoms that go along with chronic pain, and maybe it's hard to parse out which things could be side effects, which things are part of this broader chronic pain syndrome, and it certainly can make it tricky.
It can. I think one of the things that I'll do for my patients is to slowly decrease a medication or even stop it. And a lot of times patients will say, well, my pain's the same, but I actually feel better. And then I might have another patient say, my pain has gotten significantly worse, and I'd rather have some of the side effects that I might attribute to a medication than the higher level of pain that I'm experiencing off of the medication. So doing a slow kind of taper down on a medication can really help, because if we go too fast, sometimes it's confusing. You might have side effects from coming off of a medication because they can have other effects on the brain and the body. Then if you go slowly, it can often be much more tolerable, and people might feel better and realize, oh, I don't need to be on this drug.
Hmm. Yeah, while we're on the topic of medications, I'd be curious for some of your thoughts on the opioid crisis and how that is interrelated with the chronic pain epidemic that we're facing.
Well, there's many positives and many negatives. Probably more, well, it's hard to say. It's all really relative. I think this slide really highlights the fact that we have overprescribed in the United States and North America, and that's not okay. But we know that now. And now many people, it's perhaps a bit cliche, but talk about this pendulum swing. And it is true. We've seen a significant decline in opioid prescriptions, but we're seeing, unfortunately, a rise in death related to opioid overdoses. So just saying that we need to prescribe less is not necessarily the answer. However, we have prescribed too much. And I think what this slide speaks to a little bit is somewhat cultural as well, is that we have always been a society that has turned to medications more than we have to other alternative methods, sometimes driven by insurance restraints, for instance, a lack of time. When a primary care doctor only has 10 minutes to talk with their patient, how are they supposed to counsel on all the other alternatives that are out there? It's much easier to, type now, send a prescription electronically and cheaper than it is perhaps to talk about other alternatives like mind-body strategies, relaxation techniques, exercise, nutrition classes. Much of this isn't available for our patients. So I guess the answer to your question about well, what do we do about the opioid crisis and what does this mean for chronic pain, is that opioids work great for acute pain. They don't work very well in general for chronic pain. On an individual basis, some patients do benefit greatly. However, overall, when we look at population-based studies, they have not been shown to make a difference when it comes to quality of life and function, and also lead to even more issues. Some statistics actually say that up to a 20% or even more of patients prescribed chronic opioids also have a primary opioid use disorder or an addiction to opioids. So they of course come with a lot of risks and a lot of side effects. So so although we know that opioids are not first line treatments, and we know that overall high doses of opioids are generally not beneficial for the majority of patients, how are we helping patients navigate the other alternatives for pain management besides opioids? That's where the challenge lies sometimes, and that's where we need to do a better job of educating each other, as well as educating our doctors, and really working on the insurance companies to sort of look at, okay, what can we do to minimize the sort of, again, um, uh, prescribing opioids or prescribing a medication that is often a sort of reflex for a physician or advanced practice provider to do, because of the fact that a lot of these other alternatives are not always accessible or even affordable.
It's on the patient side too, right? I mean, it's a lot easier to take a pill than it is to, you know, do behavioral practices, to, you know, rewire your brain, to do all of these sort of daily practices that can take some time and commitment on the individual's part. Obviously, there's sort of issues around medication adherence and things like that. But when it comes to pain, I mean, you know, taking a medication is certainly simpler. And so I'd love to hear, you know, like what is, we touched on it a little bit, but in terms of the new model for treating chronic pain without medications, or maybe some of those that you mentioned that can have a time and place, like antidepressants or anti-seizure meds. I'd love to dig in a little more on what are the alternatives, and yeah, how does that look like from a provider perspective and a patient perspective?
Well, I think because of the opioid crisis, people are actually paying attention to managing chronic pain because they realize we didn't do a good job.
Mhm.
And that this reflex to prescribe a medication, it's not, you know, necessarily anyone's fault per se, but it is something that needs to change. And so we've known a lot about evidence-based therapies for pain control for a long time, but research has been severely underfunded when it comes to chronic pain. And so we have some a good body of research to work from, and we have more work to do. I think in the United States, at least, there is more funding available for looking at alternatives to opioids and alternatives to other existing pain care. But we know that nutrition is very helpful. We know that there's evidence for mind-body strategies and for cognitive behavioral techniques. We know that exercise is good for the brain and good for the body. And and there's lots of other sort of alternatives. And although it's sometimes difficult to do some of the placebo-controlled trials, for instance, with acupuncture, there are some out there, and they do show that acupuncture can be helpful for certain types of pain. And so it's I guess looking at a kind of menu, and that's what I do with my patients, is I think about the different categories of pain treatment, whether it's medications, other interventions like surgeries or injections, the different cognitive behavioral strategies, and the sort of what we call alternative strategies in addition to exercise and physical therapy. We can come up with that menu of what the options are and try to see if they align with, number one, patient preference, and number two, what they can afford. And I'm hopeful that we'll have some more access to interdisciplinary pain treatment, because we know these programs work. There's some excellent models in the VA system where they've seen a dramatic decline in opioid use. However, they're not seeing that rise in in pain, and they're also not necessarily seeing that patients are being abandoned. They're continuing with their providers. They're using other alternatives. So it's educating ourselves and educating our doctors and providers and each other in our communities as we sort of try to really advocate for the fact that a lot of these other pain treatments outside of an opioid, for instance, really can work. And it does take a lot of time sometimes. But I think sometimes what I hear from patients is once it's part of their routine, for instance, of bringing in the behavioral strategies or that it doesn't have to take a lot of time. You don't have to sit in a dark room for 60 minutes meditating. You can do little mini exercises. You can do other kind of mindfulness or mind body techniques throughout your day to help to kind of restructure a little bit that that again pain that stress response to pain and modify and have some more ability to cope with the pain when the pain can be quite high.
Yeah. Let's talk a little more about the role of exercise and specifically physical therapy, because I know that's often another one of those sort of frontline, prescriptions, right? You come to a provider and get a prescription for physical therapy. What's the role of PT? And I'd love to hear more in general about exercise as well.
I think we know that exercise releases a lot of good things in the brain. In particular, it seems to be more cannabinoids than opioids. But I think that getting our heart rate up is super important, especially I think some of the best science for widespread pain is really around the power of exercise and getting your heart rate up because it really does something to our own pain fighting mechanisms and increases some of those really good substances in our brain. So exercise is key, but a lot of my patients will say, "Well, it hurts to exercise, so I can't exercise," or they have other physical limitations, severe arthritis in their knee, other limits to that. So we need to find ways of getting someone to be able to get their heart rate up. Sometimes alternatives like getting into a pool is not always for everyone, but might be a way to sort of not weight bear when a limb or a joint might be painful. And anything that we can to sort of try to get that response in our body and our brain, as well as get our heart rate up, is really key. I think what's so good about physical therapy is they treat us how to not fear hurting ourselves. And so there's a term called kinesiophobia. And it's not that someone, again, is not strong or is unable to do something. It really is that this sort of often unrecognized fear that we have of re-injuring ourselves or injuring ourselves more or doing something bad. And so what the physical therapist can really coach us in is sort of what movements are okay and what are the things to maybe avoid. And that we're not going to hurt ourselves by doing certain exercises. Physical therapy can also be hard work for some people, and sometimes people feel like it makes them worse. And although that's not generally the prevailing sentiment, it can be that. So sort of finding a physical therapist, not every physical therapist is the same. So sometimes finding a physical therapist, or when it comes to exercise, a trainer or a friend or someone that you can work with that seems to be aligned with what you're doing, and that can often be really helpful. So I do have some patients who have had one physical therapist that maybe they said, wasn't really a good fit. And so they tried someone else and that seemed to work really well for them. And understanding that it's not boot camp. And so for some people they'll say, well, I'm learning certain exercises. Well, it's really about gradually improving your physical capabilities. And for many people with chronic pain, they're very deconditioned. And so it's not easy to sort of go from 0 to 60 miles per hour overnight. We need to sort of gradually come up with a program that we continue at home so that it's not just something that we do once a week with our physical therapist.
Yeah, that makes a lot of sense. That again, that's a lot of the pieces we try to incorporate into the Lin model of having a coach there and sort of someone that is a good fit for you, is someone who can help hold you accountable and keep you doing those things that are making you feel good. Yeah, I'd love to dig in a little bit more. We touched on the idea that I know you work with you said pain psychologists in clinic. Can you talk just a little more about the model that you use, and when you bring in these other providers onto the team, and how that works in practice?
A psychologist with pain training sometimes looks at things a little bit differently than a general psychologist. And there's obviously different philosophies and expertise when it comes to psychology. So some of it might be more psychotherapy based, and some of it more skills based. So it's also the same as physical therapy. Each psychologist is not always the same. So we actually have two wonderful pain psychologists, and they definitely are not the same provider. Um, and provide sort of different expertise for different kinds of patients. But that pain psychology perspective is really key when it looks at not necessarily sort of what's been going on in our past lives, but let's look at today and now. And yes, some of our experiences in the past can also modulate what's happening with our pain, but it's really focusing on today too. So it's really about how can I do again, as we talked about before, some of that brain rewiring. It's not something that we can explain in a minute or less, but it's looking a lot at how we process pain, what are our pain triggers, and how can we kind of modify our daily activities in a way that can really help improve our function. And even though we may have pain, how do we make it so, as I often tell my patients, that pain is not the boss of me, but that I'm the boss of my pain. And that's how I sometimes explain where pain psychology is helpful. And we can't all deny that pain affects our mood. And a lot of my patients will say that I wouldn't be depressed if I didn't have pain. So how do we grapple with that, and how do we make it so that patients are feeling fulfilled day to day? That's where pain psychology works. We do a lot of groups. I think groups are extremely effective. They help patients to hear from other people of sort of how they're coping. In general, they're not depressing or overwhelming. They really are very supportive and help for patients to see that they're not alone. Sometimes we feel quite alone with pain, and that group support is really quite effective. Some of that we do ongoing, and some of it is more a time limited group, like an eight week, more like skills group, cognitive behavioral strategies and mind body techniques for managing pain. Not everyone has access to a pain psychologist. So I think one of the real important aspects of Lin is that you can access behavioral health support and coaching and other ways to sort of manage pain outside of, in my case, living in the Boston area, where we are very resource rich with excellent interdisciplinary teams. That's of course not the case for most people throughout the United States and throughout the world.
Absolutely. And that was one of the big pieces we really wanted to bring into the Lin model, was this idea of having a full interdisciplinary team behind your coach, so that we have pain psychologists, physicians, physical therapists who consult regularly with our coaching team. And so it's really bringing that full integrative model into a digital format where more people can access it than might be, those that are lucky to be in your clinic. And like you said, the Boston area and other areas that might have that type of model are certainly rare.
Yes, I mean, having that in-person contact is so key. I mean, with COVID, for me, not being able to see my patients for a while in person was hard in so many ways, and yet again, to have that virtual model available has been sort of an amazing change that's happened with this whole horrendous pandemic, is that there's more availability, and more of us are in tune to that type of healthcare, which we have not always been so used to in the past. So it is, I think, an important model for that connection, because seeing someone in person, you can't always see them every day or every week. It might be months in between appointments that I see a patient, and that's not okay. So how do we improve access and continue pain support for our patients, that's where the virtual platforms like with Lin is just, I think, at the best, and really, really can help our patients to feel connected, even though they may not be seeing their physical therapist or their physician in person. They can at least benefit from having ongoing care that doesn't just stop in between appointments.
Absolutely. Yeah. Those touch points in between are highly valuable. That's sort of when all the day-to-day stuff comes up and all those questions and things that you're looking for support with in between visits. And yeah, with the telehealth model, and I think for a lot of patients, we sort of accelerated into this Zoom world as we're here today. But one thing I know we often get questions about is well, how can how can the doctor tell if they don't do a physical exam, or how can you diagnose that I have this type of chronic pain over Zoom? And I'd love to hear some of your thoughts on that, because as we mentioned earlier in the conversation, there are certainly some conversational and subjective elements to it. And how does the virtual model sort of serve this particular type of pain?
And there's, again, nothing that will replace in person, and a physical exam can be very helpful. There's, however, a lot of creative things that we can do in a physical exam virtually, and we're all learning that too. We're learning that as we go. But there's many maneuvers that I especially have learned from my physical medicine and rehabilitation colleagues, our sports medicine colleagues, of sort of excellent maneuvers and tests that we can have patients do virtually that can be excellent clues. And for me as a pain physician, it's really about the pain story. And I don't necessarily need a physical exam. For instance, I see many patients with pelvic pain, and doing a pelvic exam doesn't necessarily, I'm not a gynecologist, I'm not a urologist, that's not my expertise, but hearing the story and sort of what are the things that make your pain worse? What are the things that make them better? What can you do? What can't you do? Are often excellent clues to me about what's going on without even doing a physical exam. So, so that's exactly what I do. Is I'll ask, so what happened? That's always a clue to me. Was there a day that the pain started? Was there a moment? Was it related to an injury? Was it a stressful event? Was there any clue, or did this just kind of come on gradually and get worse over time? And most important for me is again that question of what makes it better, what makes it worse, because that can really help give me clues on what are the things that have been helpful and what has not been helpful as well. And I get a clue if someone says that my pain is worse with walking versus someone who might tell me my pain is worse with sitting. There's all these sort of different things that can help me. Or do I feel better when I'm lying down or when I'm standing up? And some of those kind of descriptors of what the pain feels like actually are important to me. So an example might be a sort of shooting pain that goes into the foot, or a numbness or a tingling. A lot of that can, to me, a signal that there might be a nerve that is compressed, or a nerve that is irritated. Whereas, someone that might feel like there's sort of a golf ball sensation somewhere, or a spasm sensation might give a clue more that this is a muscle problem. So all of those quality descriptors are really helpful. And then where does the pain go? Because there's a lot of referral patterns for pain. So even someone with hip pain could even have buttock pain, or they could have inner thigh pain or groin pain. So it's not necessarily that the pain sort of just stays in one spot. And then for me, it's not about a pain score, because most patients with chronic pain live at a high level of pain. So I want to know more about what can you do and what can't you do. And just because you can do a lot doesn't mean that means that your pain is not severe. It just helps me to understand how you're managing day to day. So even if you can go to work and you can take care of your family, you can generally do sort of social activities with your friends, that doesn't necessarily discredit someone's pain as being less pain. It just helps me to understand kind of how they're managing. But if someone spends all their day in bed, that's very worrisome to me, that something else is going on, either physically or mentally or in their home life. There has to be something else that I need to understand. This is sort of why the pain is so severe. And so those are kind of that's sort of the rubric that I follow, is sort of getting a good pain story, a pain history.
I wanted to go back to one of the terms on the earlier slide, centralized sensitization. And I'd love to hear you talk a little bit about how you think about that concept and how it, again, relates to both the pain experience and treatments for chronic pain.
I like to think of it as a sort of a change that happens throughout the brain. And some of this we can actually see on functional magnetic resonance imaging. So patient with widespread pain, for instance, fibromyalgia, has a really different looking brain than someone who does not. The same with the chronic low back pain that we talked about. And so we can see that different areas of the brain light up. So I think visually that's really helpful. But we see that you get this sort of kind of amplification of pain, this additional hyperexcitability. And that unfortunately leads to this sort of uncontrolled feedback loop where we get kind of pain doesn't go away. And that's I think where when we talk about centralized pain, that's where I'll always say the pain is in your head, because it is, because there are these central mechanisms that are really kind of making your pain experience potentially worse. And finding ways to calm that central sensitization is where some of the medications try to work, but also really in particular, the things like cognitive behavioral strategies and exercise and other therapies are really working on quieting that signal. Another way that we sometimes think about it is that a patient with pain, it's like a stereo. So you turn up that pain signal, you turn up the volume. A patient without chronic pain hears it at a certain volume, whereas the patient with pain hears it really loud. And that is another way of thinking about central sensitization. Or in my case, if I am doing an injection for a patient, I give someone local anesthetic and someone in the skin, or if I'm providing anesthesia care, a local anesthetic before putting in an IV. Sometimes a patient with central sensitization may have sort of this heightened pain response to the burning that happens with the local anesthetic. And someone without that central sensitivity or hyperexcitability will perceive it at a much lower level. And although it will burn for them, it will not be as painful as someone else. So, so that's sort of a kind of maybe oversimplified way of explaining it. But we see there's a lot of coexisting diseases with chronic widespread pain and centrally mediated pain. So patients often will tell me that they don't only have headache, they also have irritable bowel syndrome symptoms. They have TMJ or pain in the jaw joint, or they may have some other kind of nerve pain in the legs, restless leg syndrome, and all of these, or bladder pain, all of these are very, very interrelated. And I think that this picture really illustrates that, is that no, someone is not crazy, or it's not all in their head and they're not making this up. This is real. And this is based in a lot of scientific knowledge that we know that there is this kind of hyperexcitability and amplification that crisscrosses over a lot of these different disorders. So although there may not be one drug or one intervention that helps everything, there are ways that we can kind of quiet the brain. And that's a lot where the cognitive behavioral model it comes into play, is working on that centrally mediated response.
So fascinating. Thank you for that explanation. I'd like to turn to some audience questions. We have quite a few that have come in, and do please continue sending your questions. So the first one we have is, how do you address the pain that is caused by neuropathy? Yeah.
So I think with every pain disorder, we think about it from number one, what's causing it and can we stop that? So neuropathy can be caused by so many different things, but if we use diabetes as an example, unfortunately the nerves may not heal. Even if someone's diabetes is well controlled, they may have already been injured by those high levels of blood sugars. So in that case, we need to manage the symptom in addition to, of course, managing the diabetes. So always manage the cause if possible when the cause is known. And then when it comes to symptom management, it really comes to the same mantra for all of pain disorders is Let's think about medications, perhaps. Let's think about our physical therapy, desensitization exercises, physical activity. Let's think about nutrition. Of course, in diabetes, that is obvious around the dietary, but there's a lot of anti-inflammatory foods that can be really helpful. Um, let's think about acupuncture. Let's think about really all those different, sometimes some interventions. There's some injections that I do, even as something like spinal cord stimulation has been used in peripheral neuropathies. So there's again a big list of things, and sometimes patients will say, "Well, I've tried all of that, and it's not helpful." Well, then we may not have that answer right in that moment of sort of that thing, but it's also making sure that a patient is supported and that we find ways to sort of help with that connection. And I like to make sure that patients are being seen regularly to make sure that their mental health is also okay. So we definitely look at all the different things that we can do. And if we've exhausted some of our therapies or strategies, then we take a break. And we step back and we say, okay, well, how can we modify your day and modify your pain experience in some ways without it being, again, so controlling of your everyday life. And even though pain can be there, we can still find ways to make our day-to-day fulfilling, understanding that we may have limitations. So again, managing pain is uh, a little more in depth than just that explanation, but there's lots of different ways of addressing nerve pain that we just need to kind of see what's worked, what hasn't worked, and what other options might there be.
Great. Do you know of any new clinical trials for central sensitization that have promising results?
Well, I think one that Lynn is also very familiar with was a recent study done out of Boulder, and I think it's just such a cool study where they basically looked at patients with chronic low back pain, and then there was a placebo arm, there was also an interventional arm, and it really just showed that you can see on this MRI imaging, you can see sort of a remarkable change in pain processing and all the different sort of firing in the brain when you modify with different cognitive behavioral techniques. So I really think that study is phenomenal. And there have been a lot of other studies that have really looked at central sensitization and research. Again, they use the functional magnetic resonance imaging as sometimes a tool to visually calculate what changes we're seeing with certain types of treatment. But I think most of the really profound research that has come out for central sensitization has been around these cognitive and mind body techniques as well as exercise.
We can maybe share the link to the Boulder back pain study so folks have that. Definitely a fascinating protocol and outcomes. We have a question here. What is your experience with chronic digestive disorders, heartburn, LPR, acid reflux? I know that often falls with many of those sort of overlapping pieces that you mentioned with other parts of the body.
I think there's certain diseases that cause pain that we can treat using other modalities. When it comes to something like heartburn, it can be really hard. And with sort of overuse of a lot of the proton pump inhibitors, we're seeing sort of other issues that come along. So I think, it's hard. We like to think preventatively from the beginning. So we obviously want something to never be there. So if there's dietary modifications that we can make, even if it's sort of stopping caffeine or alcohol or the other things that we might enjoy, but it's not so simple. And sometimes digestive symptoms can persist despite some of the modifications that someone might make. I think it comes down to sort of making sure that there's a good team, and that you have a good team, that you have people that you trust, and then people that you can align with. And when it comes to digestive issues, generally speaking, a lot of our gastrointestinal colleagues are really sort of traditionally trained. So their knowledge really is around what we learn in our training. And so it is very medicalized. So I think a lot of patients more and more are turning a bit more to alternatives like naturopathic techniques. Um, Licorice, for instance, licorice root is really helpful for heartburn. Other things that we might do instead of jumping right to a prescribed drug. So I do find that that there are some useful things on the internet and also some really not useful things. So it can be a little hard to know how to navigate. So if someone has the financial means and ability to sort of access a naturopath, they can help sometimes with this sort of um, more or less traditional therapies. There are some physicians also trained in alternative medicine and board certified in that field, and so that's sometimes uh, someone that I might recommend where it can be covered by insurance because it's a physician visit for some people. But it is sort of thinking a little bit outside of the box and always looking at what the triggers are for pain and seeing if there's any way to modify those triggers is really helpful. But back to the fact that it can take a team, so it may not be just a GI physician and a primary care doctor that can help modify, but it might also involve seeing someone with pain expertise or consulting with Lin on other ways to sort of modify that pain experience can be really helpful too, or nutritionist. So really involving a few different types of people.
Again, that integrative model. Have you treated anyone with chronic pain due to long COVID?
I have, and there was a recent New York Times article about pain after long COVID, and perhaps we can find that was in New York Times Magazine. Um, we're learning a lot, and unfortunately, the severity of the disease of COVID does not necessarily translate to the severity of complications or pain. And I have seen, and there's some excellent NIH-led research that's being done right now. So I think we'll have more information in the next year. I do find that nerve pain is often what patients talk about. So that might be kind of neuropathic pain, nerve pain in the extremities. I have a few patients where it's getting better, but it's been a long, long struggle. And so I think we have a ways to go, but we'll still manage the pain like we would any type of pain, which is symptomatically manage it. And unfortunately, there isn't a lot that we can do to combat the havoc that the virus has caused on the body and the brain. And so I'm hopeful that with time that majority of the patients can improve, but we are seeing a large percentage. I think they're saying now 1 in 5 patients with long COVID symptoms, and that can include pain.
Yeah, definitely an emerging area where hopefully more data and research will emerge. Let's see, we have a few more here. Another audience question. So I'd really like to get off of pain medications, but I'm afraid of the rebound pain. What are some of the steps that you recommend for people to start?
So go slow, and don't be and try not to be too afraid. Um, it's very overwhelming, and remember that a lot of the medications that we use for treating pain, whether it's opioids or antidepressants or the anti-seizure medications, do have do change our bodies and our minds. So there's profound physiologic and neurological changes that happen. So the slower we go, the better someone does. In the case of opioids, for instance, if someone is on a really, really high doses, if you go super slow, it's going to take years for someone to get off of a medication. So I think it's kind of looking at all the different um, factors, including the dose of a medication, to sort of help with that. Also the most important thing is contact with a provider. With antidepressants as well as opioids, we have seen sort of increased rate in suicidality as well as sort of other mental side effects of tapering a medication. So we want to have contact with someone and also make sure that they're feeling supported and understand that there can be side effects with tapering, and to know what to look for. And sometimes there are some other things that we can do to kind of quiet those side effects. And if someone's having side effects with the taper, to relook at what are the side effects, and is it possible to go slower? And that can be it. But I've always found my patients is once they feel ready, they always can do it. And if we sort of push someone to taper a medication, it just doesn't work as well. So if you're feeling ready, I could go for it.
Awesome. Okay, we have another great question here. It's a little bit long, but lots of great tidbits packed in here. So can you address the challenges posed by imaging? A lot of patients become really attached to the notion that their spine is quote unquote damaged. And this belief is often reinforced by pain specialists who prescribe repeat steroid injections. These can often fail to bring meaningful pain relief. And payment structures also can reinforce invasive interventions, as we talked about a little bit around the sort of default patterns in payers and prescribers. So how can we help increase pain providers' knowledge around the need to not only target structural issues, but that psychosocial, biopsychosocial model and contributors to persistent pain?
Well, that is awesome. I'm a disclaimer, I'm an interventionalist, so I can stick a needle anywhere I want to, with my expertise and guidance. And I do find that for some patients, they provide short-term benefit, and others longer-term benefit. But it is true that the way that our insurance model is set up now is that they will essentially cover a lot of things, including interventions, but they cannot, will not necessarily cover some of the other things like long courses of physical therapy or some of the other alternatives that we've talked about. So I think this is going to change. I think we are really moving towards a bundled healthcare system where people will say, here's a lump sum of money for your patient that has chronic back pain, and you health system do with it what you want to do, but you're only going to get that amount of money. And so spine surgery, for instance, or injections are extremely costly. Whereas a behavioral health appointment may not be as costly in the long run. It can be sort of more upfront costs, but that doesn't necessarily translate to higher costs overall. So I also think that we're going to be thinking more preventatively. So how do we keep our patients healthy before they develop certain types of problems? How do we work on obesity? How do we work on exercise? How do we work on stress? How do we sort of do all of the good things, access to good nutrition, and so a lot of these things as a society, we're going to need to do a better job. And as the insurance is structured appropriately to be able to reward for good outcomes and again, preventative. But that's, I think, very far out, the preventative aspect of it. Although much is happening with certain insurers who are incentivizing patients to be healthy and to watch their weight, diabetes risk factors, smoking, etc. Some insurance companies will even pay a patient for being healthy. We will move away. I think where the healthcare system is going, we are going to move away from these costly interventions like injections, and but some of it is about access. So there might be someone who has access to a spine surgeon and interventional pain doctor, but they don't have access to behavioral health or even a social worker that might help someone with some of the other sort of home stressors that they might be dealing with, or with job counseling, or some of the other things that we see more in a socialized healthcare system. So I'm not sure when or how we'll get there, but I do see more and more that insurance companies are actually paying less for some of these costly services. And so it may even force us in the healthcare system to find other ways to treat pain that we know are effective, but traditionally have not been covered by insurance.
I think we have time for one more quick question here, and then we'll wrap up. I think it's maybe a good and closing one, which is, so I've had some improvements, but I'm feeling stuck. And what do you recommend? So it sounds like this person had tried a little bit of this sort of dynamic model and maybe worked on the behavioral and cognitive elements, but started feeling a little bit stuck.
Sometimes just taking a deep breath and sort of taking a break. I think sometimes we're hard on ourselves and we set the bar really high, and it's easy to get frustrated that we might not be making progress as quickly as we would like to. Congratulate yourself first that you're doing a great job, and your pain may have its sort of ebbs and flows. Some days it may be worse, or even weeks it may be worse, but it can get better. And to control that sort of fear response of, am I ever going to be normal? I think also a lot of times I coach my patients, let's not think about being pain-free. Let's make our goals so that they are sort of stepwise. Of course, we want everyone to be pain-free. Unfortunately, as we mature, we're all going to be faced with different kinds of pain problems. And sort of how do we make it so that, again, they don't rule our day-to-day? There's ways that we can sort of modify activities and, again, be proud of the progress that you make, even if it might be slow. But taking a deep breath, stepping back for a moment, and sort of saying, and a lot of times it's a lot of work too to help treat pain and to manage your pain on a day-to-day basis. So find ways to also do something to reward yourself for the hard work that you've been doing.
I love that. A great note to end on. Thank you so much, Antje. This has been incredible and very educational. And I hope we had lots of great questions coming in. So I hope the audience enjoyed it. We wanted to just let everyone know that at Lin, we just launched a brand new 3-month pain recovery bootcamp with guaranteed pain reduction results. And we also have a monthly plan with the same amazing programming, but it allows you to go at your own pace. If there are any providers in the audience, we have a referral program. So if you're interested in sending some of your patients to Lin, please reach out to our team. And we also are offering an exclusive promotion. So if you use the code webinar20, you can take 20% off the Lin membership. This is good through Sunday, May 29th at midnight. So a limited time offer. And if you sign up for the 3-month bootcamp, you can save 20% off the full price. And if you sign up this week for the month to month, you'll lock in that 20% off of the monthly rate forever. So awesome promotions. Please take advantage of those. As we've talked about, there aren't a lot of places around the country to get this type of integrative care. And so we've really strived to make Lin accessible and really bridging those gaps in treatment, and looking forward to collaborating with providers like you to really get the word out there and start making this paradigm shift in how we treat and reimburse chronic pain care.
Absolutely. And I think so patients will get everyone attending today will get a follow-up on how to sign up if they're considering.
Yes, we'll send out an email also with the recording. So be on the lookout for that. Probably it'll take 24 hours or so. And yeah, we can go ahead and we'll post that, the discount code and the links in the chat. And thank you so much for your time and everyone for listening in.
Thanks for having me. Bye.